Now we'll have another panel discussion on various case scenarios, moderated by Dr. Professor Paul Abrams, and the panelists are Dr. Sanjeevan K, Dr. Changal Varayan, Dr. Mujib Rahman, Dr. Lalita K.
Well, I have the honor of giving the last talk, I think, and I'd just like to say, while most people are still here, another very big thank you to Professor Chawla and the USI, firstly for helping us to set up the urodynamic course, and then for organizing this superb 2 days on lower urinary tract dysfunction. So thank you very much. So I'm going to talk about a few bits and pieces that I've been asked to discuss with you. Discussion will be minimal in order that lunch is not delayed and you can get your flights and everything back. But if there are questions and Professor Chawla allows it, we can do questions. So I'm going to talk about voiding dysfunction, vaginal mesh problems, and the role of estrogens. So, of course, if a patient has voiding symptoms, then urodynamics may well be indicated. And we have a variety that we could think about, but we're going to start with flow rates and ultrasound, of course, and then move on from that. And what we're looking for from urodynamics is to assess detrusor function, and the only significant abnormality is going to be detrusor underactivity, and we talked about that yesterday, so I'm not going to talk about that today. In terms of urethral function, we're obviously looking for failure of relaxation / obstruction. So we can think about whether the urethral function turns out to be normal or whether there's obstruction. If there's obstruction, is there a functional obstruction in the sense that the urethra looks normal but it doesn't work properly during voiding? Now that can be due either to pelvic floor overactivity or urethral striated muscle overactivity. There may be a mechanical obstruction, urethral stenosis, stricture. Bladder neck obstruction, I think, is pretty rare in women, but of course we do see patients who've got a significant anterior wall prolapse which kinks the urethra. But again, urologists in urodynamics don't see many of those patients because quite sensibly they get a pelvic organ prolapse repair first because the prolapse is bothering them. So what about the definition of obstruction? Well, there's a bit of a problem there, and I can't actually remember how we decided that these were reasonable figures, but we pretty much would have guessed. We would have said, well, that's a low figure, everyone would agree that's a low figure, and everyone would agree that's a high figure. Why don't we pick these figures? Now, Blavis and Grouts, a bit later, they came up with the same flow rate, but they put a lower pressure on it. And they came up with this nomogram, which says you could be severely obstructed. Well, nobody would disagree if the pressure was over 100, and they'd also agree it was certainly obstructed over 80. And then they relate flow to pressure here in order to come up with no obstruction with low pressure, high flow, and here mild obstruction with a lower flow rate and a higher pressure. The point is we will never be able to discriminate obstruction from no obstruction in women in the same way as we can with men. And largely that's because obstruction's rare. And somebody mentioned it's less than 5% of patients we see in urodynamics for women as opposed to 50% that we see in men. And in women it's a variety of conditions. In men, it's almost always prostatic obstruction. So it was relatively easy to create a nomogram of obstruction in men, and I don't think it's easy at all in women. Nevertheless, we have to use clinical judgment. High pressure and low flow does equal obstruction. So a couple of cases of important but relatively small groups of women. So this woman is quite young, 27, and she gave a 2-year history of difficulty voiding. And a year previously, she'd gone into urinary retention and had a residual urine of 400. She had no neurological signs. They took her catheter out, and she failed with a post-void residual of 760. So what comes next? Well, In fact, we established her on intermittent self-catheterization, and you can see these are the catheterization volumes. So she was catheterizing 5 times a day, nicely spread out, and you will see bladder sensation, no sensation, no sensation. So she has lost, or never had, it's a bit difficult to know, proper bladder sensation. So she had an MRI, even though we often do this, and I expect you do too, in young men, young women with no obvious reason. We do an MRI, and they're practically always normal. So we don't get any further, and we end up saying this idiopathic voiding dysfunction. She was, after the catheter was removed, obviously, because she had to have a catheter back in with a residual of 760, she didn't want to use the catheter all the time, so she was put onto ISC and referred for urodynamics. Is urodynamics justified? Well, I think in a 27-year-old who can't void, for reasons we don't understand, the answer is probably yes. It might not influence management, but if nothing else, we need to build up our understanding of this group of patients. So this is a urethral pressure profile, okay? And I've mentioned over the last couple of days that we find it useful, and this is another group of patients that we find it useful. I'm sorry, this slide is missing the bottom for some reason or other. So here, the catheter is in the bladder, it's being pulled through the urethra. This is the mid-urethral point, this is the distal urethra, and this is the outside. There it's been put back in, and a second profile is done there. So if you just look at this bit, the pressure here is about 110. The closure pressure is 110. The average for a young woman of this age would be around 60 or 70. So she has abnormally high urethral pressures. And the finding in these young women, and they're usually young women, it's very rare in men, in these young women, is that they have very high, abnormally high urethral pressures. If you do ultrasound of their urethral sphincter, which as you can imagine is slightly tricky because the urethral sphincter is a little bit small, but if you're really clever at ultrasound, then you can show that these patients have a higher volume of their sphincter, of their striated muscle sphincter. So the sphincter is hypertrophied due to overactivity. So high pressure, normal bladder filling, in other words, no detrusor overactivity, and she couldn't initiate a detrusor contraction. And in normal physiology, perhaps that's not surprising because she couldn't relax her urethra because of the very high pressure. So you don't expect, therefore, the patient to initiate a detrusor contraction. So we would define this as idiopathic urinary retention, also known as Fowler's syndrome. The etiology is very poorly understood. At one stage it was thought to be associated with hormonal abnormalities and polycystic ovaries, but it certainly isn't in all patients. The pathophysiology is striated sphincter overactivity. I think we've seen enough patients to know that. The natural history is unpredictable. She went into retention and never got out of retention. Quite a lot of these young women have retention episodes, and in between they void adequately well. I'm not saying they void well, but adequately well. How do you manage them? Well, if they void adequately well, you leave them alone because they're not that easy to treat. If they don't void adequately well, then intermittent self-catheterization is the treatment of choice. But it's very difficult for some of these patients. And they give a very characteristic history that when they catheterize, the catheter comes up against a wall. And then if they push, it goes in. So what it's coming up against is this high pressure sphincter. They get it in, and then they empty their bladder, then they try to get the catheter out, and sometimes they can't get the catheter out because of pain. So what has happened, I'm sure, is that the catheterization has put the external sphincter into spasm. And the pain, I think, is just like a muscle cramp that you might get in your leg or your arm, because it's striated muscle just the same. The pressures are so high that I think the muscle becomes hypoxic and they get pain from it. And I had one patient who just used to leave the catheter in and leave the bathroom, and eventually it would drop out. So they can find intermittent catheterization extremely difficult. Nevertheless, that's simple and safe, and that's what we do first. If that fails, then these patients have a good, about 70% response to sacral nerve stimulation. So it's one of the two primary indications we have, refractory OAB, detrusor overactivity, or this condition. Now, the next patient is a different sort of problem. At the age of 6, she was having urinary infections, and she was referred to a urologist in another town. They said she had poor flow, and they postulated that she had dysfunctional voiding. Now, just to remind you, dysfunctional voiding is usually seen in kids and is some strange learned behavior where they keep contracting their pelvic floor during voiding. Nobody quite understands why this occurs, but if you give them pelvic floor biofeedback, they can often learn to relax their pelvic floor much better. Anyway, she didn't have any of that treatment. She then obviously had overactive bladder, and when she came to see us, she'd also developed stress incontinence. She'd been wearing pads since she was 18. She'd had anticholinergics and 5 lots of botulinum toxin. She did ISC for 4 years, and at one point needed an indwelling catheter for almost a year. She also had functional bowel problems, fibromyalgia. She was a very big lady in all senses of the word. She was nearly as tall as me and a lot wider than me. She smoked 10 to 20 a day. Well, what next? We decided to do her urodynamics because we didn't understand what was going on, and she had interrupted and fluctuating flow curve, which is typical for dysfunctional voiding. On filling cystometry, here we're filling the bladder, red for rectum, blue for bladder, green for detrusor, and you can see she had repeated involuntary detrusor contractions, some of which caused urinary leakage. So that explained and reproduced her overactive bladder symptoms. And then when she came to void, she reproduced her interrupted fluctuating flow. And you can see that there is a an opposite effect. When flow goes down, pressure goes up, and vice versa. So if you just look here, this bit here, the flow has gone down, the pressure goes up. The flow has gone down because she's closed her pelvic floor. She then opens her pelvic floor, flow goes up, and the pressure goes down. So this is characteristic of detrusor sphincter dyssynergia. So, a slip of the tongue, but you understand why. It's exactly like detrusor sphincter dyssynergia. This is dysfunctional voiding because she is neurologically normal. And it's the pelvic floor and not the intrinsic urethral sphincter. So what other tests should we have done? Well, she'd gone through all this period and she had not had a bladder diary. So if you look at this, so 2 days, here she's got her fluid intake, and here she's got her urinary output. Well, remember she's catheterizing, hence the big volumes. But have a look at her fluid intake. 250, 250, 450, 250, 250, 250, 250. Then she goes to bed. At midnight, she drinks 1 litre. At 3 in the morning, she drinks 1 litre. And at 8 in the morning, she drinks 1 litre. She has a massive fluid intake, particularly during the night. So you're beginning to think this patient's been under our care as the urological community for 30 years almost. She's never had a bladder diary. How can we manage this patient? So this is what I meant when I talked about taking a holistic view. She's got all the other problems that go with a functional disorder, which is other functional disorders. So beware of a patient with multiple functional disorders. She's also got fibromyalgia. The other common ones are cluster headaches, irritable bowel syndrome. None of these conditions have what we would call a proper diagnosis. These patients have multiple problems, and they also, of course, have psychological problems. She presumably must be addicted to fluids. And we cannot help this woman who has an almost 6 litre fluid intake. She has no diabetes, not diabetes insipidus. The next person she needs to see is a psychologist. She doesn't need some urologist to say, well, I can cure this person. Well, you won't be able to. They had a jolly good try in the other hospital. So beware of these patients with functional abnormalities when you can't really understand what's going on. Don't just do another treatment. So as I've said, the pathophysiology is pelvic floor overactivity. In children, it's relatively easy to reverse. She was pretty hopeless, quite honestly. She denied any possibility that there were any psychological issues going on with her. I think her natural history is entirely predictable. I think, sadly, she will carry on having lots of problems from lots of parts of her body. But conservative management, biofeedback, and ISC, which she is prepared to do, is the right decision, I think. So in these patients, try to make a precise diagnosis, given that we often don't really understand very well exactly what the problems are. Select an appropriate treatment for that patient, and it might be psychological counselling, warn the patient of possible problems if you're going to intervene, and of course properly informed consent. So I'll talk now a bit about mesh. So this is a lady with stress incontinence, TOT in 2005, TOT in 2006, because the first one didn't fix her. And then she still had stress incontinence, so they put in a third tape, TVT this time. Nothing like a bit of variety as there in life. Post-operatively, after 3 tapes, she was dry. Wonderful. But, as you might imagine, with that amount of plastic around your urethra, it becomes difficult to pass urine. And she had to do ISC for 3 months. So how dim is that, to do 3 operations? Now, TVT and TOT, let's face it, are good operations. In the vast majority of patients, they either cure the patient or make them very significantly better. And we did a randomized controlled trial of TOT versus TVT. What do you think the cure rate was, panel? The cure rate?
So with TVT, the long-term cure rate is about 85 to 90%.
Okay, next please.
I don't live facial slings, so I can't say from my experience.
Sorry, what's your percentage?
No, I don't, I
No,
use
no,
only
you're an
facial
expert,
slings.
you have to give a percentage. What's the percentage cure from TOT, TVT?
70 to 80%.
80%?
We have done TVTs only mostly, and most
percentage,
of
please.
percentage probably around 80 to 85%.
Experts can never answer the question, can they? Depends on your definition of cure. Well, cure is not being wet. That's easy. But it's a good point, because when you look in the literature, people define using 1 pad a day as cure. Well, that's nonsense. Why would you go around with 1 pad a day if you're cured? So cure then, what percentage have no leakage?
Almost all my patients didn't have any leakage. They were comfortable. So we probably took that as the cure.
Did he say a percentage? He's a tough nut to crack. All right, I'll pretend he said 100%. You're wrong. So, in fact, in our study, which was more than 200 women, the cure rate was 67%. What do you think the satisfaction rate was? Because that's what's important. And women are realistic. If they're very wet, they will say being almost dry is fantastic, would be fantastic. In fact, the satisfaction rate was 95%. So in all stress incontinence surveys, if you take proper measurements by patient-reported outcomes, the cure rate's about 2/3. It's the same for artificial sphincters, so sadly it's not 2/3, it's about 50% are actually dry. So anyway, she was dry, lucky thing. But then she was referred back because of recurrent urinary infections, and of course that's a big red flag. Is that because she's got a big residual urine and she can't really be sorted out until she empties properly? But then she also started to complain of groin pain. She was a slim woman. So the next step, obviously, was we don't usually do cystoscopies, but you'd be a fool not to in this case. So this is a view from the sphincter, and here you can just about tell this is one or other of her tapes, which is eroded through. So she is one of the patients that we see, particularly in Bristol, because we have a big referral practice. That doesn't mean that tape erosion is common, but when it occurs, it can be very difficult to deal with. So Hashim, who works with me, and I did a U-shaped anterior vaginal wall decision. We removed all the TVT. We also, of course, to do that, had to do a suprapubic incision as well, and we removed as much of the TOTs, plural, as we could. By the time we'd removed all those three, the urethra looked pretty dodgy. And in fact, of course, it had a hole in it. It was bound to have a hole in it because there was a TVT or a TOT right across it. How did she do? Well, not surprisingly, she was very wet afterwards because we hadn't done anything about her sphincter. She had no real sensation of bladder filling, and she was using 10 to 12 pads a day. No sensation of filling because she probably wasn't really filling very much. As soon as any volume came in the bladder, she leaked. We did her urethral pressure profilometry, 0 to 100. She should be up here somewhere. She has almost no urethral function. So we did a Marcius graft to provide some support to a poor urethra and put in a rectus sheath sling, and she did well with intermittent catheterization. This lady, she'd had previously had a TVT 3 years ago and now came back with frequency and nocturia, mixed incontinence, and 2 pads a day. So she again had never really been dry. And again, the bladder diary, this is an old style bladder diary, is vital in assessing these patients. She had a reasonable looking flow rate, no residual urine, so it didn't seem that voiding dysfunction was the problem. Here's her filling, good quality trace. You can see all this small activity in the rectum, and the bladder subtracts out well. Well, that's a bit suspicious, isn't it? And as we go on, we can see that she had involuntary detrusor contractions, and in fact these correlated with her symptom of urgency. So her main problem after her operation seems to be urgency incontinence, although you'll see here a leak accompanied by these coughs. These are very big coughs. That still means she's got stress incontinence, but for her, urgency incontinence was the problem. So you will see mesh problems, but of course if you spent your whole life doing colposuspension, you would see a lot of the very similar problems. The only thing you wouldn't see, of course, is erosion, because there's nothing to erode unless you unfortunately put your stitches in the wrong place at the time of surgery. So back in 2011, there were a group of women who decided that the urologists and gynecologists in Britain were not taking them seriously. So they formed this group. At the time, TVT was the most popular operation. That stands for Mixed Up by Mesh. And this is the official petition. And this has really gained a lot of positive movement for these disaffected patients. So this is from the Eastern Daily Press from this year, a month ago, when the Health Secretary, the boss of the NHS in Britain, visited Norwich to speak to women affected by the surgical mesh standard. Now, the surgical mesh standard not only affects stress incontinence, it's also about pelvic organ prolapse mesh. And he said, hearing firsthand the stories of women who've been badly affected by surgical mesh implants. Well, of course, he didn't talk to the other 95% who actually were quite happy with their TVTs and TOTs. But these women are extremely vocal, and as you can see, they've got themselves into contact with the highest levels of political power. So what happened next? The government ordered the halting of vaginal mesh surgery to avoid the further risk of life-changing injuries to women. The Guardian is a newspaper, and it's a reputable newspaper. It claimed to have done research to find that 1 in 15 women given a mesh implant later required surgery. Sadly, unlike Scandinavia, our data systems do not allow such a statement. We don't really know what the incidence is. We know from a study we were involved in, it's 5%. So it's 1 in 20, so maybe they're not so far ahead. Now, of course, 1 in 20 isn't many, except that there are a lot of these operations done every year. So the government accepted the use of vaginal mesh implants to treat complications after childbirth should be stopped immediately. So it was stopped, and at the present, if a woman has stress incontinence, she's offered a Culpo suspension, a fascial sling, or as you pointed out, rather useless injections into the urethra. Those are the 3 things that are agreed. What does the BAUS website do? Well, the BAUS website has been very sensible and has just put information out into the public domain so patients can access the BAUS website. Does the USI website have a patient area in it? So I would just make these points that it was a mistake to mix up mesh for pelvic organ prolapse and mesh for stress incontinence, because there are really big problems with mesh for pelvic organ prolapse, and indeed those who also use it for rectal prolapse. There are even bigger problems. And one obvious way is because the mesh that you put in for a prolapse can be as big as that. And obviously the mesh you put in for stress incontinence is a skinny little thing. It's a much smaller volume. So volume seems to make a difference. As I've said, perhaps 90% of women are perfectly happy with the outcome of their operation, but precise data to know how many patients are happy and how many patients have complications is not available, but it's probably about 1 in 20 have erosion. Mesh is not regarded as a major problem in most countries, which is fascinating to me. You'd expect in America that if there's a complication, everybody will be looking to sue the surgeon for $3 million. And the only country that seems to be replicating that is actually my country. Scandinavia, it's not a problem. Most of Europe, the people I've asked, they say it's not a problem. Here I understand it's not really regarded as a problem. So something's wrong in all this. And I hesitate to give my diagnosis because it might be detrimental to the reputation of our country. But there are problems, and patients need to be warned about that. Late mesh complications may occur, and we've had one of our patients in the original TVT versus Culpo suspension trial erode at 10 years, which is why I said earlier, I've never advised younger women to have it because we don't know what will happen in 40 years, particularly in younger women after the menopause with relative atrophy of the lower genital tract. Maybe it'll become much more common. Mesh removal is difficult. There are multiple ways of doing it, but the best way is by open surgery, which is a bit sad for the patient. Laser's been described, but of course that can't remove the whole of the mesh. You can only remove the bit you can see in either the bladder or the urethra. We need a proper algorithm about when and who we remove mesh, because there are some, I would say, rather unscrupulous people in the UK who are removing mesh just for pain. Now, I say unscrupulous because, in fact, if you look at women after Culpo suspension, a proportion of them have pain. And actually, a proportion of them had pain before the operation, so people have pain. And just because you have pain doesn't mean that it's the mesh that's the problem. So it's a very difficult situation to sort out. So I would suggest you watch this space. And then finally, I was asked to say something about estrogens. And for the gynecologists here, should urologists be prescribing estrogens? Well, yes and no. no, I don't think we should be prescribing estrogens for the menopause in general. Unless you're all short of things to do, I would leave that to the gynecologist and perhaps the competent general practitioners. But yes, we see patients with lower urinary tract dysfunction, and there's good evidence in some situations that estrogens are a good idea. Now, the EAU guidelines say when you examine a woman, you look at the perineum and assess estrogen status, and I hope all of us here do that. What about the evidence? There's some good evidence for estrogens in lower urinary tract dysfunction. There's evidence that urgency and frequency, so part of the OAB syndrome, is improved by estrogens. Now, by estrogens, I'm talking about topical estrogens. Because as you know, parenteral estrogens after the menopause are not widely recommended these days. And many patients would refuse to take it. But we prescribe topical estrogens and we reassure the patients these are extremely safe. So topical estrogens can reduce most of the OAB, but they don't affect incontinence, either urgency incontinence or stress incontinence. There's good evidence for preventing recurrent infection and, of course, for treating atrophic vaginitis. So the February this year guidelines on urinary infections say consider using the lowest effective dose of vaginal estrogens for postmenopausal women with recurrent urinary tract infection if simple measures have not worked. So this is a high-level, nice recommendation, and I spend a lot of time putting older women onto vaginal estrogens because most of the patients that I see have either vaginitis, urinary tract infections, or overactive bladder symptoms. So they all are counseled about vaginal estrogens. And there is good evidence, and I certainly have a personal friend who's an older woman, and they just switched off her urinary infections, which had been bothering. She's about 80, this woman, and she'd had urinary infections for about 20 years. And the vaginal estrogens, which had never been offered to her, I said to her one day, have you ever been asked to take vaginal estrogen? She said, no, it's never been mentioned. And they switched off her infection. So there's good level 1 evidence that that works. And of course, there's good level 1 evidence that if the woman has vaginal atrophy and dryness in the vaginal area, discomfort, problem with sexual activity because she's sore, then vaginal estrogens are extremely good for that. So I think urologists certainly should be asking about these issues, including asking about sexual function, if you see that a woman looks obviously atrophic. What other thing? Well, it'd be interesting to hear your view about this. It seems like a good idea before stress incontinence surgery, from our point of view, and maybe you do it before prolapse surgery, is to give the patients 3 to 6 months of vaginal estrogens to improve the quality of the vaginal tissue, knowing also that the way it works for us, urologists, is it also changes the quality of the urethral and bladder-based mucosa as well. So, I hope this 2 days has made the point that functional urology is fascinating, but it's also very challenging. I would say for the young doctors, don't waste your time going into prostate cancer and doing robotic prostatectomy, because that's going to be cured in 10 years' time, and you'll spend 20 years not knowing what to do with the rest of your professional life, and you'll end up growing mangoes at some farm in the countryside. Well, that would be nice. Stick to functional urology. There's not much sign that we've sorted out most of the things we've talked about. That's not because we're stupid, it's because they're inherently rather difficult to sort out. Thorough assessment with bladder diary is essential. Management has to be holistic. Don't forget lifestyle advice and behavioral modifications. Surgery is reserved for the minority of patients that exist with overactive bladder, even with stress incontinence. If you ask most women who've had children, they will tell you, if they're honest, that when they have a really full bladder, if they have a coughing fit for some reason or other, they'll lose a little bit. So most women, I would say, have a little bit of stress incontinence, but they certainly don't want an operation for it, very sensibly. So reserve our operations for well-selected patients. And in general, both our patients and us need a lot of patience, really, to manage their problems. And of course, bladder pain syndrome will be one of the very good examples of that. So thank you very much.
Thank you, Dr. Paul, for an enlightening talk on various topics of LUTD. So actually, I just wanted to talk about the voiding dysfunction, which is so common in women in our country, starting right from the childhood, from their school age. And one of the things which I observed, and which every child or even adolescent, young woman come out with the history of postponing their desire to void. This is a very common history in many of the women with voiding dysfunction. I don't know what is the experience of the the seniors here and Dr. Abrams. Yes, in our country, right from the school age, the young girls, they usually tend to postpone the desire to void in their school hours. They come back home, they wait till they come back home. So this, if it goes on for a long time, I have observed many of these women come with lower urinary tract symptoms, mostly the pelvic floor dysfunctions and voiding disturbances. The pelvic floor dysfunction. Yeah. Some of them may have the storage symptoms too.
Yeah. Well, it's probably related to a reluctance to use school toilets, isn't it?
Yes.
And of course, we have exactly the same problem to some degree. And women, I think, are able to hold on longer. I think their bladders are less thick-walled because they don't need to be as powerful as a man's bladder. A man's bladder is much more powerful because it has to be to get urine through the long urethra with a prostate, etc., etc. So I think we call it the shop assistant's bladder. I don't quite know why, but because they had to sit for hours, in the shop serving, etc. And so presumably a group of these patients have susceptible bladders that if they're repeatedly overstretched, then eventually they don't work very well. So I agree it's a problem, and I suppose the school authorities should be making sure that they provide sensible and safe, I suppose, safe toilets. I'm amazed how many women in England do something called, I forget what they call it, but floating over the toilet. So they actually might stand on the edge of the toilet so they don't sit, because their mothers have told them that they'll get a urinary infection if they sit on the toilet, which is clearly quite untrue. So there is also an education necessity in UK and maybe in India too about that.
Thank you very much for the patient hearing. I think we should disperse for lunch. Yeah.
Yes. And now we'll be having a panel discussion on various case scenarios on bladder pain syndrome, moderated by Dr. Sanjay Sinha. And the panelists are Dr. Sanjeevan K, Dr. Rajiv TP, Dr. Ali Poonawala, Dr. Lalita K.
And I'm back with you, standing between you and lunch. There's a quiz in between too. With standing shoulder to shoulder with Lakshman, between you and your lunch. So we're going to, over the next maybe 25 minutes or so, we'll be 20 minutes we'll be discussing about bladder pain syndrome. And Dr. Subnis has really given us an excellent, let's say, background to this discussion. I think he made a very difficult subject, he made a very lucid presentation on a difficult subject in his guideline presentation. So we'll have two brief case discussions, and I'll try and bring out some of the important points for the audience, and this is what the objectives of this session are. We'd like to be able to understand how to define bladder pain syndrome, like to identify patients who might be suffering from it, develop some kind of a customized strategy for evaluation, learn how to counsel the patient and to formulate a plan for treatment. So over the next 20 minutes, it's a somewhat challenging thing for us given the timelines, but let's try it. So let's examine this case history of a 46-year lady who presented with pain in the suprapubic region with urinary frequency, urgency and nocturia for 3 years. She has no voiding difficulty, normal menses, has had 1 cesarean section in the past. She has no hematuria, bowel symptoms, she's non-diabetic, has a marked interference in her regular activities because of her bladder symptoms, and she is now feeling emotionally disturbed. Her clinical examination is unremarkable. She has a normal, healthy vagina, no prolapse, no specific tenderness specific at any point on her vaginal exam, a normal digital rectal examination, a normal abdominal examination. So let me ask the audience, the panel first. Given this history, do you believe that this history is consistent with the potential diagnosis of a bladder pain syndrome? Because the first challenge that our clinicians face is when to consider a diagnosis of bladder pain syndrome. So would you say that this kind of a presentation would at least raise, even in the first visit, a potential for bladder pain syndrome diagnosis?
It is a potential bladder pain syndrome as long as we have ruled out urinary tract infections.
Right.
Cultures are very important.
So Dr. Ali, how often would you get a patient with recurrent urinary tract infections with this kind of a 3-year presentation? And let me put it in another way. How would you differentiate a urinary tract infection presentation from this presentation?
So I think the fact that this would be a long-term spectral event rather than episodic generally, that would be the first point of differentiation between a recurrent UTI in somebody with whatever pathology and BPS.
Okay, so maybe we'll revisit this issue in our next patient. So for the time being, let's look at how to define bladder pain syndrome. And essentially all definitions encompass 3 things. There needs to be a pain which the patient feels originates from the bladder. There should be some lower tract symptom along with it. And there needs to be an element of chronicity. Now, how much chronicity is required, it depends on various guidelines have different definitions. It needs to be enough for you to understand that there's an established problem. It doesn't seem to be something transient, it's not going away and so on. So the minimum duration given by any guideline is 6 weeks, but some guideline would tell you 12 weeks. So there needs to be an element of chronicity. And they should, as Dr. Lalita very rightly pointed out, you should not have any other explanation for these symptoms. We will come back to this issue of other explanations in a moment. But you need to do due diligence and make sure that you're not missing something. So all these, there's some conditions like overactive bladder, a bladder pain syndrome. The onus is on us as a clinician to make sure that we are not missing critical diagnoses. It's possible for somebody to have a very serious life-threatening diagnosis presenting just as overactive bladder. You all know about it. You could have a flat CIS of the bladder and it could present, a carcinoma bladder can present just like OAB. So the onus is on us to make sure that we are not missing a different diagnosis. So these are 2 definitions I brought here for you. This the EAU definition on top. Bladder pain syndrome is the occurrence of persistent or recurrent pain perceived in the bladder region accompanied by at least one other symptom such as pain worsening with bladder filling or daytime or nighttime frequency. No proven infection, no other local pathology. AUA, an unpleasant sensation, pain, pressure or... Yeah, go ahead.
I'll shout, it's okay.
So you can give a mic. Yeah.
Your patient had urgency.
Right.
So it's important to talk a little bit. It's important to just say what we mean by urgency. So you'll see that the new definition does not have urgency in it. So urgency is reserved for overactive bladder. So that does confuse the history in your particular patient.
Right.
Now, it used to be urgency for either fear of pain or fear of incontinence. So if you say to your patient, do you have to rush to the bathroom? She'll say yes. But it's not because she thinks she'll leak. It's because she thinks she's going to, well, because she'll
have an uncomfortable sensation.
She'll get much worse pain. So it's a shame. We should have, the definition of urgency should have actually been urgency for fear of leakage. That would have made it much clearer.
Sure. We will actually, that's something that I have somewhere later in the presentation. But anyway, so you need to, so one issue here is the issue of EAU definition puts recurrent here, which implies that the problem goes away for substantial points of time. Not very common, but certainly it's usually persistent. A very short interval, pain-free intervals might be there in some patients. Now, A lot of you know these, and I've just brought this here, the NIDDK, ICDB, and so on, so to tell you that these criteria which were there for making a diagnosis of the so-called interstitial cystitis, which you don't want to use that phrase, or bladder pain syndrome, were never meant as diagnostic criteria for managing your clinical patient. They were meant as research tools. They have either high specificity or high sensitivity, but they're not really the right kind of tools that you should be using to make a diagnosis. So this woman had this kind of a frequency volume chart. And she was passing very small volumes repeatedly. And to make the point which Professor Abraham said, I was about to actually get to that. So the relevance of the frequency. When you see this kind of marked urinary frequency in the patient, you need to ask the patient what is driving the frequency. And many times the patients just don't understand what's driving the question. So you need to specifically ask the question that if you feel like passing urine, you're outside in the open somewhere where there's no toilet available, what will be the first sensation that you get? Is it a feeling of urgency? Is it a burning discomfort or pain? And typically when you ask this question, they'll come out with the right answer. What about the relevance of nocturia? So let me ask the panel. Let's say if this woman was not getting up in the night to pass urine, would you still entertain a diagnosis of bladder pain syndrome or not?
No.
No?
No, if there is no nocturia.
Professor Abrams, if the woman does not get up in the night.
Oh, sorry, if they don't. I have once seen a patient with Hunner's ulceration who had a bladder capacity of 700 ml.
Right.
And that's totally the exception.
Right.
So I agree. If they're not getting up at night, it's very unlikely that it's certainly a Hunner's ulceration and probably not bladder pain.
See, if you go by the definition that I showed here, the definition says and or nighttime frequency. And certainly we have about 180 patients now in our database of bladder pain syndrome. We have a few patients in whom who do not get up in the night and still complain of pain. It's not essential that they actually should, none of the definitions say that it's mandatory. But as you said, the usual patient would be getting up in the night too, and certainly it would raise doubts in my mind as to what we are dealing with if this patient has this kind of a frequency in the day but doesn't get up in the night at all.
Especially if there is so much frequency in the daytime and if she's not getting it.
Right. So just a little bit more about the definitions. So if you look at the definition for bladder pain syndrome, it says there should be at least one other symptom which localizes the problem to the urinary tract. And the reason why they've put this there, say, vis-a-vis the prostate pain syndrome, is that the symptom of the localization to the bladder is more difficult clinically. I mean, you can palpate the prostate and say the prostate is tender. It's very difficult to do something equivalent with the bladder. You need something additional. Yeah, go ahead.
Actually, that's very badly worded. If you read the fourth line, that means they do have to have nocturia.
This one?
So actually, yeah, that means they do.
It's written
so
and
it actually should be written nighttime urinary frequency with or without daytime. That's what that actually says.
But that's not what is written.
Pardon?
That's not what is written.
That is what it says. Daytime and
with bladder filling and daytime or nighttime.
Well, it's pretty ambiguous then.
Yeah. This is pasted here from 2019 EAU. So that's what I'm saying.
No,
so this implies that nocturia is not a prerequisite. That's what this implies, this definition.
No. I think the other way around. You have to take it.
No, I have not taken it other way around. It's very clear. And oblique or means both things are possible. There's no ambiguity about this language. Let's not try and overinterpret what's written here.
I think Paul is hungry.
No.
And oblique or means?
No, and or means there's always nocturia. That's what it means.
No.
Yes.
No, Paul.
Sanjay.
You are the Englishman, but I differ with you.
I demand a vote. We're in the world's greatest democracy.
Right.
Okay.
And if you look at the AUA definition, increased frequency is not a part of the definition at all. Okay. Let's come back now. Now, the three main things which confuse us or confound us are bladder pain syndrome, overactive bladder, and UTIs. And I have put here a small table which does not come from any textbook. It's my take on it.
Because
you may or may not agree or disagree, and you can tell me if you disagree with me on what I have written here. So typically, the duration of UTI, the patient has a shorter duration of history, typically. An OAB patient often has a chronic history, and a bladder pain syndrome patient almost invariably has a long history. If you look at absolute symptom-free periods, with UTI, almost invariably you will get symptom-free periods. So there have to be periods in between when the patient has zero symptoms, no symptom at all. So the point I was raising about a 3-year history, if the patient says that I had long periods or substantial periods where I've had zero symptoms, it could still be episodes of UTI. But a UTI will never give chronic, unrelenting pain day after day, unless you go by, there are some researchers in the UK who believe in the entity of chronic UTI and keep treating long-term antibiotics. There's a publication this year also from their group. The third is nocturia is common in UTI, but it's transient. In overactive bladder, it's common, but it's almost invariable in bladder pain syndrome. And finally, pain is pronounced in UTI, but again, it's transient and usually during voiding rather than during storage. It's uncommon in OAB, and in bladder pain syndrome, it's pronounced transient, not transient actually, I should have written here at storage. The transient word should not be there. So, yeah, go ahead. Yeah, short comment. Yeah.
Yes, so then regarding UTI, unless you have a proof, you should not say the same way. It's not a soundless.
No, I'm telling you how to clinically, because these are the 3 main confounders. See, the common things that you'll get in an outpatient are urinary tract infection, overactive bladder, and bladder pain syndrome. Our biggest challenge in treating these patients, I'll tell you, is patients come to us with a history of 10 years. Nobody's entertained a diagnosis. See, treating bladder pain syndrome, at least to make the patient comfortable enough to carry on with life, is not difficult. I'm not asking you to cure a patient. Getting to the stage where the patient says, I can manage life, is not difficult. The challenge is, as clinicians, we do not entertain that diagnosis at all. So you need to first be able to have the confidence to entertain that diagnosis, and this helps you do that. Agreed. We'll come to that problem of UTI. We'll be discussing that. We'll be discussing that issue of UTI later. We will discuss that issue, okay? So what's the plan? So this woman had a normal urine examination. Her ultrasound was normal. A uroflow was done and was normal. And so what next? Do you think this is sufficient for initiating therapy in our patient?
Yes.
Right.
If we go by the guideline which was mentioned by Dr. Subnis, we require cystoscopy.
I was about to come to that. So would you always do a cystoscopy at this stage? So would you do a cystoscopy?
No, I can
Cystoscopy?
Not at this stage.
Cystoscopy?
We would put
Dr.
her on
Rajiv?
empirical medical treatment first.
And in
Cystoscopy?
cytology at least, I look for AFB also.
Okay. Okay. So if the urine exam is normal, you would still do a urine AFB
This is a
examination.
random sample daytime, so I will collect a few samples of the early morning and send for AFB,
Okay.
which is obviously common.
Okay, in our experience, getting a normal urine exam in patients who are having tuberculosis is very unusual. If they have bladder symptoms, I'm not talking a renal tuberculosis, but bladder symptoms secondary to tuberculosis with a normal urine exam in our experience is very unusual. What about a Professor Abraham, cystoscopy, where do you position it? Do you do a cystoscopy at this stage?
No, I agree with you.
Yeah, I think I would actually.
You would? Because there'll be a corollary question follow-up to that if you say yes.
I think I would. If the patient had significant symptoms, and this patient really has got a lot of problems, I think I would go to a GA cystoscopy.
Okay.
And I say GA because I think it's cruel doing
Absolutely, I agree. So bladder pain cystoscopy is ideally under GA. Okay, so the next question I'm going to ask you is, would you do a hydrodistension?
Well, that's why I would do a GA cystoscopy, yes. So if I saw any evidence of glomerulations or certainly of Hannah's ulceration, then I would take the opportunity to do a hydrostatic dilatation.
So now what would have happened is, given this patient's background, she came to you with this presentation, and even before you've tried any kind of medical management, you've given her a hydrodistension. Do you think that's good science?
With that frequency volume chart and those symptoms, with the exception of apparently urgency, which I interpret as urgency because of pain, which is why she goes so often and she voids such small volumes.
So you are basing your decision to do a cystoscopy at this point on the mean voided volume, is that it? So let's say her mean voided volumes were 150.
Yeah,
would you do a cystoscopy at this point?
Because I think one important thing you can do with a general anesthetic cystoscopy is to see what the real bladder volume is. And that discriminates, obviously, to some degree between Hannah's ulceration and other types of bladder pain syndrome, because in Hannah's ulceration, usually they have small bladders. In the other types, they very often have completely normal-sized bladders.
So I don't dispute you're doing a cystoscopy. The only thing that I would do is reserve the cystoscopy at this point, because I land up in a situation where I'm offering an invasive therapy before even having tried any other initial therapies at all. Yeah. No, but she's not been, a diagnosis of bladder pain syndrome was never made for her. No. Patients who have not had a diagnosis of bladder pain syndrome would not receive therapy for it. She would have received a dozen courses of antibiotics. That's what happens.
So that's
we know that they are molecular. Anyway, so
yes,
the point I want
only after we try medical
no problem. So there's no right and wrong in this. The EAU guideline says you should also do a cystoscopy, but they don't position it where you should be doing it in the algorithm. In the sense whether you should be doing it at this point. Personally, I wouldn't do my cystoscopy at this point. I would initially put the patient on therapy before I do.
How about cytology, Sanjay? Would you do cytology for her?
You mean a urine cytology
yes,
for malignancy?
CIC, yeah.
For
CIS, yeah.
So if you look at the indications for a cytology, among the indications for cytology, just pure frequency is not actually an indication for a cytology.
No, in this patient, would you do or not?
In this patient? Ordinarily, I would not be doing a cytology in this patient.
Dr. Sanjay, in our...
Yeah. No, urine routine is normal. I've already given you a normal routine exam.
Only if there is hematuria. Yeah, it's very obvious.
You wanted to say
well,
something?
I think the cytology is a relevant suggestion. This woman is suffering. She could have so-called malignant cystitis, which is what you're talking about, isn't it?
Dr. Sanjay,
but the fact is she's suffering, and I wouldn't have it. I don't have a great deal of faith, as I said earlier on, in the oral therapies for bladder pain syndrome. And if I do a cystoscopy, and I'm saying that because of the severity of her symptoms, I've got a chance of giving her one of the only two treatments which I know are pretty good. One is lasering or whatever, proper Hunner's ulcers, and the second is hydrostatic dilatation.
I mean, you know that getting a Hunner's ulcer is a very remote possibility.
Yeah, sure.
The proportion of patients is very, very small.
But the second, being able to do a hydrostatic dilatation
Fair enough. Okay,
might well give her some relief
Sure.
immediately.
One more point. Before you do all this, would you like to put a local anesthetic into the bladder to see whether she has a relief with her from her pain?
Yeah, that would be reasonable.
I mean, do you do it as a matter of routine?
To see if you can change her bladder volumes.
So two issues. If you put a local anesthetic, do you think that in some way stratifies your patients in terms of how to manage them? Patients who respond to the local anesthetic vis-a-vis patients who don't?
I don't think we've got enough information to say that, but it would certainly be a potential way of phenotyping patients, but it's not done in a systematic way, is it?
Right. You wanted to say something, Rajiv? Yeah.
we would have done some imaging tests before that, like an ultrasound would have been...
No, she's had ways. Yeah, we've done all that. Yeah. Okay. Let me just go to the end of this patient's presentation and tell you what we did, and then go on to the next one, because I have a very short amount of time here. Counseling of the patient is important. We put this patient at amitriptyline, escalated that to some extent. She had good relief for about 6 weeks and feels about 80% better. There are patients who respond. They may not respond in terms of becoming normal, but a substantial number of patients will actually feel better with medication. It's not always sustained. Now, if a patient does feel better, now what? She's come back to it's about 3 months. Do you continue the treatment? Do you escalate it further? Do you taper it? Do you stop it? What would you do?
Continue the treatment.
So how long should effective treatment be continued?
How long what?
How long would you continue effective therapy, medical therapy? Let's say you put patients on medication, they're okay. Indefinitely?
Well, I think they're so unpredictable, these treatments.
Yeah, so you don't have good evidence to back up what you do. So it would be a reasonable proposition to try and withdraw the medication or taper off and see what happens. But there's no good evidence really how to continue. So we continued at the same doses, attempted to taper at about 3 months, which is what we usually do. Often we're able to get the medicine dose down, and we usually do this because when they have their next exacerbation, we again have an ability to go up. Because if you don't taper down when you can, then it's difficult to go up further when she comes back with another exacerbation. I'll go on to the next patient quickly. I have another 5 minutes or so. Huh? Okay. Next patient, let me skip through all of this quickly. So again, 62 years, women presented with pain in the suprapubic region, urinary frequency, urgency, nocturia, 7 years, voiding difficulty, occasional. The reason I put here for both these patients urgency is important to understand that not all patients who have bladder pain syndrome will come and tell you they have pain. And when they say urgency, please ask them why the urgency. So this should be a matter not just for bladder pain syndrome, for all your OAB patients. As a matter of routine, any patient who comes and says, I've got frequency, I go more often, you need to ask them what happens if they are not able to access a toilet. That's very important, even for OAB patients. You must do it as a matter of routine. Everything else was essentially unremarkable, but this is the part that I wanted to discuss with you. She's got a lot of tests with her. 2 out of the 8 urine examinations she has shows pyuria. She's got 2 positive cultures and out of 9 cultures which she has. 2 of the ultrasounds show somewhat elevated residuals. 1 uroflow is excellent. The other one shows an interrupted 12 ml per second flow. So let me now ask my panel, what's the relevance of pyuria and a positive culture in this kind of a patient? A long history, a fat file, lots of reports, which you'll find in many of these patients. Some of these patients will have like a big file, multiple reports in it. And it's almost invariable. If you do somebody's urine examination 10 times, take it from me, a couple of reports are likely to show you pyuria. Yes. Same for the culture, we know that.
I think the first question to ask is, were they actually collected properly?
Okay, so let's assume that they've been collected properly, and she had pyuria, which obviously is not so susceptible to the collection process on 2 of the occasions.
So, it obviously complicates your diagnosis of
the reason I'm putting it here is that this is very common.
Yeah.
So how do you sort this out? So the patient comes, she's got a fat file, 2 cultures positive, 2 reports of pyuria. How do you sort this out with the patient? How do you decide? So I'll tell you what I do. Again, it's not from a textbook. So what I would do is, I would ask her, are you symptomatic today? She says I'm symptomatic today. I'll tell her to give a fresh sample now for a urine exam. And if that urine exam is normal, then I would be comfortable still retaining my diagnosis of bladder pain. So I would actually ask, today, how are you feeling? And then do a urine exam. And if today's report, she does show pyuria, and then I'll send a culture, obviously, to follow up, then I would treat her and see what happens and probably put her on prophylaxis, go on a different route. But if I find that today's report is normal, I would still retain my diagnosis of possible bladder pain syndrome based on this.
Yeah, that's what it doesn't mean a woman with bladder pain syndrome will not get an infection.
Yeah. What about the elevated residuals or the flow? So again, these patients sometimes will not void well when they are in pain. So if they've got severe pain, and this you'll see if you ever do a urodynamics on a woman who has bladder pain syndrome, you will find that the post flow that you do will be much worse than the pre-flow that you do, the post-test flow. Because when the bladder is distended and then they pass urine and they're having a lot of pain, at that point they're just not able to pass well. So many patients with bladder pain syndrome will show you the odd report with elevated residuals or a poor flow. Doesn't necessarily rule out the diagnosis. Again, I'm not saying that it makes a diagnosis. Doesn't necessarily rule out the diagnosis, provided you can show that they are able to void well when they are pain-free. So the question I would ask them is, was this uroflow done when you were pain-free? And again, I would ask them, are you having pain today? And if they say they are not having pain today, this is the time when I would check for their voiding efficiency. So if she says, today I don't have pain, I'll check her flow and check her residual. If today everything is okay, then I would still be okay with my diagnosis of bladder pain syndrome, because at the times when they are pain-free, I would expect them to be able to void well. Okay. So again, this is all that we have discussed. We would always send these patients and get a multi-department. Okay, I didn't go. Actually, I'm completely running out of time. So let me. So this is the O'Leary Sant or the ICS, the interstitial cystitis scaling. Yeah. Sorry. No, we don't use it for diagnosis. We just use it as a kind of benchmark to see the patient's symptoms to follow them. That's all. So all our patients get this at each visit when they come, but it's not a diagnostic questionnaire. Yeah, absolutely. Good point. It's not a diagnostic thing. Okay, so she was started on oral medication, but she doesn't respond well, still not comfortable, and that's the stage at which we've now planned our cystoscopy, and that's her cystoscopy. So that's the initial cystoscopy under general anesthesia. She had about a 200 ml capacity under GA. I think I need to speed this up a bit. It is pretty short. And this is after her bladder was emptied and refilled. There's no specific ulceration seen, but you see a lot of bleeding points, which could just be a patient who has a bladder which is chronically underfilled. We know that, a chronically underfilled bladder could sometimes produce all these same findings as you might find in your patient with, for instance, BPH for that matter once in a while. So nothing very specific here. We did not take a biopsy. Do you take a biopsy from your patients?
No, biopsies are pretty useless, I agree.
So unless we find anything...
This doesn't look very normal to me.
It doesn't look normal. I mean, so this is post-distension. The pre-distension was relatively better, just a few...
At 200 mLs?
Yes, at 200
so
mLs.
That's a very good physical science. She has a small, truly small bladder.
True. So what is the relevance of the diagnostic findings of all these things that you find? So regarding the Hunner's ulcers, Professor has just told us repeatedly that finding a Hunner's ulcer might be a key to getting resolution in a patient. But what about the other things? The capacity, the glomerulations. Would you in some way stratify your management based on the patient's bladder capacity?
Yes. Yeah.
Do you use OAB medication in your patients? Do you use OAB medicines in the medical management of any of these patients? Overactive bladder medicines? Antimuscarinics or Solibes or Mirabegron?
No, not normally.
You don't at all?
I mean, if she really does have urgency, yes. Urgency for fear of leakage, yes, I would.
Okay. So what we would do is patients who got low mean voided volumes frequency, we would actually put them on OAB medicines in combination with other therapies, including amitriptyline and so on, but not the other patients. I think I should probably stop now. I will stop now. I think I can see from the organizer. So I must thank Professor Chawla for having given me an opportunity to be here with you. I've really enjoyed my 3 days here. This is the longest that I've ever spent on any of these meetings. Typically this duration is for a national conference, but you've managed to keep us here for 3 days, and we are grateful to you for it. And we really enjoyed our game of tennis last evening. Thank you for everything. We really enjoyed our stay here. Thanks.
Thank you, sir, for a wonderful discussion.
Thank the panelists.
Now we'll be having a quiz session hosted by Dr. Lakshman Prabhu.
Yeah, thank you, Arun, for this opportunity. And we have reached a phase when most of us are underactive. And yet, you are doing justice to that diagnosis of underactivity by, a decent, reasonable residue, I would say, that many have left. I think with your permission, and I'm told that there are only 20 prizes, so I'll have to slash 5 questions. We can have fun with those 5 questions, but I think we'll... rules have been already announced by Dr. Sanjay Sinha. I thought I'll save some time. It is open house. Those who know the answers can, raise the hand, stand up, identify yourself and give the answer. And immediately your prize will be delivered. You are ready with the prizes? Okay. Now, which of the following is not a feature of bladder pain? A, it is felt suprapubically. Okay. No. See, sir, you are tired, sir. Come. Yes. Not for you. Okay. Praveen, not for Praveen is a scholar now. You are already a fellow.
Urodynamic. Please stand and in this. Yeah.
The answer is C. Yeah. That's correct. Because there's nothing called, in medicine, always. Okay. You have to read the mind of the question setter. Okay. Next. Which of the following is not true for frequency volume chart? A, it records time of each. Yeah. There. C. Can you explain why C? Right. Very good. I think, shall we have this? Yes. Professor is around. This is taken from his book, Urodynamics. Who made the statement, the bladder is an unreliable witness? You have the options. आप बताइए सर. Bakes, yeah. 2 चॉकलेट देना है. एक प्रेसिडेंट के लिए, IPP के लिए. Yeah.
It is nice to share with all my friends.
Yeah. What is the approximate age by which most children acquire adult type bladder function from the reflex type of an infant? Yeah, there. You there. A is not correct? Yeah, give him a chocolate. 5 is correct. Which of the following antimuscarinic agent is regarded? Yes, there. B. Why? Can you explain?
It doesn't cross the
Blood-brain barrier, yeah. Quaternary amine doesn't, yes, correct. Which of the following is not a treatment option for overactive bladder? Yes, yes. Thank you very much. That's right. Give him I think he deserves 2. Which of the following statements is not true of stress incontinence? You gone through it? Yeah. No. Yes. Yeah. D, yeah, D is right. Abnormal sphincteric mechanism. You expect the sphincter to be normal. Yeah, this is straightforward. Yes. Bladder capacity. Can you tell us the formula? Yeah, 30. Yeah, right. Or in ounces. Yeah. I think this is for the gynecology. I thought, I should have this. Which of the marked ligaments is used in McCall-Kuldaplasty? I think we had a gynae crowd. They've left? So they are all marked. So, you have to identify the ligament. Yes, ma'am. There you are.
C.
C is right.
Thank you. I'm right?
Yeah, you are right. Uterosacral ligament. I don't know whether these are the latest. I think, Dr. Sinha can correct me. The International Children's Continence Society defines dysuria as C. Who said C? Yeah. You said, who said first? I didn't see. Okay. There, you heard the, yeah. That's right. Burning or discomfort with urination. Many dislike this word, dysuria, but it's still there. The processing of control on when and where to urinate occurs in? Yeah, correct. Give him a chocolate, yeah. I think we can have a round of applause, you see, once in a way, you see, whenever you get a correct response. Yeah. I think, yeah.
You must not put S. Whenever you write centimeter, S should not be.
Yeah, I'm sorry, madam. In a suspected case of interstitial cystitis, no, yeah. Just you saw the clip, the video. What should be the height above the bladder level at which the cystoscopist keeps the irrigation bag to demonstrate glomerulation? No, 60 is not correct. Sir. Did you get 2 chocolates? I think we'll have to take one. Okay. Anybody? Yeah. There, yeah. 80 is correct. There, yeah. Yeah. No, it's approximate, ma'am. Thank you. Considered. Yeah. You stay, yeah. Stand up and answer. Curtsy, yeah. Okay, this, it's called Vincent Curtsy, and it's after Dr. S.A. Vincent of Belfast. Now, I think this is a very important question. What percentage of children with urinary incontinence due to neurogenic bladder can be rendered dry with anticholinergic therapy and regular CIC? Yeah, A. Majority of them, yes. Correct. Give, I think, yeah. Which of the following is not a feature of poor outlet resistance as the primary cause of incontinence in a case of neurogenic bladder? A. Funneled open bladder neck, detrusor leak point pressure less than 30 to 40 centimeters of water, history of stress urinary incontinence, and trabeculated bladder. Yeah, trabeculated bladder, correct. Akshay, yeah, deliver the prize, yeah. Which of the following is not used in the treatment of overactive bladder? Yeah, madam, there, yeah. Madam answered, I think, 2 or 3 questions, you see. Yeah. Value of sacral nerve stimulation is not established in all except. No. Wait, don't be in a hurry. In 3 conditions, it is not established. 1, yes, it is established. Value is established. Wait. Yeah, stand up and say, which one? Option D, urgency frequency, correct. Which is the most constantly observed symptom of attention deficit hyperactivity disorder? Sleep enuresis, frequency, daytime enuresis, retention of urine. No? You said, yeah, that's correct. Daytime enuresis and urgency is the commonest symptom. Yeah, what is the histological diagnosis of VC? This is bladder, this is detrusor. A, normal, B, obstructed, C, inflamed detrusor, and D, scarred detrusor. Inflamed, one more try. One more try. No. See, you can't expect a urologist to, with normal, with difficulty he might. So it is normal detrusor. Now, no, there is a bonus. One more. Can anybody tell us why detrusor is called detrusor? Etymological question. Well, this is a nice to know area. No, not. Wait, Detrusor is from detrudare, means to push out. Yeah. I think, ma'am, please don't answer. For which of the following is this device used? D is wrong. B is correct. Yeah, give him a chance. B is correct. Pelvic floor. Yeah. Which of the following injectable agents for stress urinary incontinence is no longer used? Yeah, doctor. Yeah, I think, sir, I think you could answer the next 3 questions. We've run out of chocolates. Round of applause for Dr. Vase. Correct, answer is correct, Teflon. Yeah, yesterday we learned this. Neurocontrol of voiding in infants occurs at. Who said that?
Look, everybody is waiting.
Yeah, give it to her. Which of the following is not a suggested mechanism of giggle incontinence? This is a condition which is very difficult to demonstrate by urodynamics. Yes, congenital detrusor weakness is the correct answer. Yeah, round, I think, please applaud. Which of the following is not true of underactive bladder or detrusor underactivity? We learned this yesterday. Poor bladder emptying, predisposition to urinary tract infections, occurs as an isolated. It can coexist with other LUTD. This is what we learned yesterday. Correct. Which of the following is not true for bladder bowel dysfunction? Pay some attention here. It's crowded. Treatment of chronic constipation results in resolution of incontinence during day as well as night. B, efforts at achieving pelvic floor relaxation during voiding is beneficial. Mirabegron can be safely given to children with BBD. Adequate hydration is a prerequisite for timed voiding in children with BBD. Not true? No, wrong. C, I don't think we have as of now robust evidence, as to the safety of mirabegron, though there are studies, as recently as 2016 we have some prospective open label studies, but the safety has not been established. Thank you very much. And I think Professor Paul Abrams, I think you must be very pleased with the performance, sir, because you took a lot of pains to teach us.
Before I ask Dr. Anish Srivastava, Chairman BOE USI, to come and propose the vote of thanks to all, there are a few panelists who couldn't get memento or a token of appreciation from the organizers. So may I request Professor Paul Abrams to come and just give the memento. Dr. Sanjeevan, he was not there yesterday.
Don't write so much, just to read. Mohan Suvarna. Mohan Suvarna.
Dr. Lakshman Prabhu.
Sujata Patwardhan. Mujib.
Dr. Lalita. Dr. Rajiv TP. Dr. Nagraj is there or left? Dr. Nagraj. Dr. Nagraj. Dr. Nagraj H. Dr. Sujata Patwardhan. Dr. Ajit Wade. Dr. Ajit Wade.
Thank you, Paul.
Okay. Oh, thank you very much. Thank you, Paul, for doing the honors. May I request Dr. Anish to come and just say a few words before we break for lunch. And
thank you. So, friends, every good thing must come to an end at some point. But in this program, I wish, and I think most of us wish, that it could have continued for another few days and we could have learned more words of wisdom from Professor Paul Abrams. And many thanks to him for conducting this program, and we are all tremendously benefited. And then I also thank all the faculty members for taking care, for teaching us for all these 3 days. And I think finally it's the team, the organizing team led by Professor Chawla needs a big round of applause. And all the volunteers, all the students from Department of Urology and from Manipal. Thank you everyone. And I think with this we go for the lunch. Is it all right? Okay, thank you.